Start with the EMR, the electronic medical record, or EHR, electronic health record. I think most people on this call, most people who will be listening to this later, understand the need to digitize health records. I also think most consumers of healthcare and patients are immensely frustrated with the number of patient portals. The fact that you have a different digital avatar of yourself as a patient in the ER compared to CVS's or urgent care minute clinic compared to your primary care doctor's office. And people are infinitely frustrated that the electronic records aren't talking to each other. There's therefore disparate care. And as a primary care doctor, I can attest that I spend enormous amounts of time helping my staff call information from, the urgent care where they got their tetanus shot on vacation and the cardiologist whose different EMR, electronic health record, doesn't interface with my electronic health record. So what do you say, Bob, to the patient, the consumer of healthcare who's thinking to themselves, oh my gosh, the electronic health record made things seemingly simpler, but made it more complex. And how am I going to be expected to maintain privacy of my records and then integration of care when we already have, technology making things more complicated?
Well, I don't know if this will feel good for the patients, but they should know that the doctors are every bit as frustrated as they are for having the information in 50 different places. So this is one where the federal standards are beginning to create more of a central kind of marketplace. Obviously, in a perfect world, all your information would be pulled together, would be in a single place that would help you manage your own care, would help the doctor take care of you, would help. You saw during COVID that much of the useful research on COVID treatments was coming out of the UK and out of Israel rather than the US, in part because those countries have a single medical record that knows you wherever you go. If you're in the VA system, there's a single record that knows you wherever you go. So this is something that I think is going to be important, is somewhat aspirational. I think AI helps a little bit, but doesn't solve the problem. This is a problem that has to be solved by through federal legislation that forces all the companies to sort of, and we have systems like that. The banking system is one where I can take my Bank of America card and put it into a Citibank machine, and I can even put it into a Banco Santander machine in Barcelona, and it knows who I am and spits out money. So it's doable. It's been a flaw, I think, in legislation and politics. But I guess, Lucy, where I sit, that's a huge problem with the electronic health record. But probably the bigger one is both patients and clinicians spend a huge amount of time on these systems and get so little useful intelligence out of them. And from a doctor standpoint, I liken it to if you had a little baby and you spent all your time feeding and changing the baby and the baby never smiled at you. Think about the amount of time you spend documenting and so little useful intelligence and insight comes out of it. That I think AI can help with, both decreasing the amount of time you spend documenting and in paperwork and all that, and also increasing the chances that you're going to get some useful recommendations, insights out of it. And I think the same thing is true on the patient side. The patients all have a patient portal. Again, yes, you're right, that may not be a perfect representation of all their data, but at least some of it. And now by federal statute, they get to see your note and my note. They get to see the lab results, their x-ray results. And like, what does that mean? My magnesium's low and my EKG's abnormal. What does that mean? And the portal gives them absolutely no assistance. And except for one little thing, which it gives them a little button at the bottom that says send a message to your doctor, which of course drives the doctors crazy because they now have 3 hours of work to do after they put the kids to sleep. So all of these are areas where I think you can take the electronic health record and build in artificial intelligence to deliver more useful support for both clinicians and patients.
Yeah, I mean, as a practicing doctor, primary care for over 20 years, 25, I guess, I can attest to what you're saying. I know you can too, that, you know, the act of caring for another human being is relationship based. It's rooted in trust and rapport and understanding the whole person. It has everything to do with integrating the social emotional context of the patient's situation with their lab data and their test results, and then communicating that nuance to the patient to empower them to go out and go forth and make healthy decisions based on their risk tolerance and their particular medical issues. So it strikes me that yes, AI promises, I think, to make the paperwork side, the documentation side more efficient. And perhaps, I'm hoping, I actually do believe to elevate and not eliminate the patient-doctor relationship. Because I think what people worry about, and certainly doctors, I believe, worry about this, and doctors who care about talking to humans and think it's an important thing, they worry about AI coming in and doing the work of the relational aspects of care. But if AI is going to come in and help me finish my notes and integrate the ER report with the reporting from my own lab, then that is going to actually give me more time to look the patient in the eye and to lay on hands and to say, help me understand what I can do to help you.
Yeah, and we're already seeing that. I mean, the diffusion and uptake curve of AI scribes, I don't know if you use one in your office, but it's been astounding. I mean, unlike anything I've seen in the history of medicine, as has been the uptake curve of knowledge tools like open evidence, where really in the space of a year or two, it went from a new thing to like everybody has one. And that really reflects both the sort of superpowers of the tools, but also the profound needs that the clinicians were feeling to sort of have tools that help them get through their day. I think in many ways, the tools like a tool that can summarize a patient's old record or scribe your note or draft a prior authorization request to insurance companies are all really important. And I think they are, but to me, they're singles, they're not home runs. The real home run is tools that improve or increase my ability to make the right diagnosis, give you the right therapy, that understand the context, know enough about you. And I think these tools have the capacity to do that. They're imperfect now, and I think particularly as we think about rolling out tools like that for patients, I worry a little bit about that because in some ways the quality of the tool is dependent right now on you putting into it a prompt that reflects a lot of knowledge and experience on your part. When patients use it, it's a little dicier because they may not know of the 5 symptoms they have, which ones, or the 10 medicines they're on, which ones are salient. But I think the tools are going to get better. And I agree with you on the relationship part. I actually try to go in with an open mind, and to say I'm rooting for the humans. It's too painful for me to believe that patients don't need to or want to see me, particularly times of great need or complexity. On the other hand, if I'm in San Francisco and I look at my phone and I see an Uber is 2 minutes away and a Waymo is 9 minutes away, I will wait for the Waymo. And the relationship I have with my Uber driver is not that important. Obviously, I'm not comparing that to medicine. But there are parts of life where we used to think this is all about the human connection, where we've given up some of that because of the convenience or the cost or in some ways, the quality of an alternative way of doing it. And I can imagine a world of primary care where people are still seeing you for complex problems and the relationship part of it. But there's a fair amount of what is taking up your day today, their vaccines or the medicines for their travel, or maybe even managing their cholesterol, their blood pressure, that probably doesn't need your level of intelligence and experience, and could probably be done more cheaply and more conveniently by AI if we organize it right.
I think that's right. I think what I'm hearing from you, Bob, tell me if I'm wrong, is that there are certain things that don't require an MD, um, that require just a really, really well-trained AI.
Yeah,
The question, though, is who is gonna make the decision as we steward AI into medicine? And by the way, it's already here for medicine. It's already coming. I mean, medicine is coming sorry, AI is coming for the healthcare system. AI I think, wants to replace the healthcare system in many instances. But how are we gonna ensure we, doctors who understand what care is, what AI is unleashed upon, and what is reserved for the interpersonal human sort of trust giving relational aspect of care? And do you worry that if tech alone is given, free reign over the healthcare system, like Silicon Valley kind of thinks they could, that the doctors are kind of incidental to the whole experience of medicine. The doctors are kind of cogs in the wheel. We're sort of like they will maybe be relics in the future. But
dinosaurs, legacy providers,
right,
the guild, and they are used to hearing that from industry after industry and saying, blah blah, we will build this thing that's better than you, cheaper and more convenient. So the concerns are correct, real. The CEO of an AI company has not taken the Hippocratic Oath. They also they're used to selling their tools to people that can afford to buy it and not used to and don't really understand anything about taking care of a patient who doesn't speak English, who is a 80-year-old widower who lives in a third floor Chinatown walk up. Um, and there's a long history of tech coming into AI, coming into medicine, saying, we've fixed retail or we did travel, we're going to do medicine, and leaving with their tail between their legs, not understanding
Yeah.
the regulatory environment, what it means to take care of a sick person, all that sort of stuff. I think we have to have a voice in this, but there are other voices as well. Patients will make their own preferences known. The malpractice system will have a say here. The regulatory system will have a say here. But, this can go in a lot of different directions. And I think it's fair to say that all of the actors, and I would say including physicians, will to some extent act according to their economic self-interest. And so that could take us off the rails very, very quickly.
Two examples of patients I saw this week, Bob, that to me are emblems of why we need humans in medicine. And of course, I'm self-interested. I am a human. I'm a doctor. I spent my whole, I sacrificed my 20s to be a doctor. Glad I did. So I'm a little biased on the human necessity in the caregiving enterprise. I also think that, yeah, AI could do a better job and a quicker job than me of prescribing someone antibiotics for strep throat, right? Or making a quick diagnosis. It doesn't need an MD. Um, but for example, a patient I saw this week was ambivalent about getting an MMR booster. This is not common in my patient population, but very ambivalent. Someone who is listening to, our current HHS and talking about, well, kind of pushing back on the data on MMR without a complete set of data in front of that person. And it took me, emotionally regulated. I live in DC, so I'm trying not to,
Stay
pick fights.
calm, stay calm.
Stay calm, stay calm, Lucy, stay calm, and sort of explain, first of all, why I understand where you're coming from. I hear you, I understand you, I understand where that vaccine skepticism is coming from. And let me explain to you why I think it's important to get a booster when you're not immunized and why your child is going to probably need a booster as well. But that, I don't think an AI could do. The second patient I saw this week, we have a huge snowstorm where we have a ton of ice on the streets. People can't get to their cars. It's a mess. So I have an 80-year-old patient who came in and his blood pressure was high and he was accompanied by an aide. Um, and I said, "Oh, what's going on with your blood pressure?" And it took him a minute. He was embarrassed. He hadn't been able to get to the pharmacy because he was snowed in, so he hadn't been taking his medicines. Had I not been listening or paying attention, I might have just said, an AI might have just said, ratchet up his blood pressure medicine, double the dose. And then he would fall out because he had taken too much blood pressure medicine. Those are probably instances where the AI could actually provide empathy and curiosity about their vaccine skepticism, where they may be able to ask the question, Mr. Jones, maybe did you forget your medicines? But, I will probably die on the hill of humanism into medicine. And I don't think you disagree that humans are required to care for other humans. I also am very pro AI. I'm very pro AI. It's already helping me every day in my workflows. I guess the question is, are you overall a proponent? Are you overall a skeptic? I think you're a proponent, but where do you see the most benefit for the sort of healthcare system at large? Where do you see the most ROI for AI? Is it really in the administrative day-to-day? Is it in diagnosing people? Is it the scalability across the country, given that 100 million Americans don't have access to a primary care doctor? What do you see as the brightest light out there?
Yeah. Well, first of all, yes, I would say I am an optimist in part because the technology is spectacular in many ways, and it's only getting better. I mean, every day it's better than it was yesterday. And the unmet, and I think in some ways unmeetable needs. I mean, you probably
Right.
know the study that showed, for a primary care doc, if all you do is prevention, that's 27 hours a day. That's if no patient has the temerity of actually having anything wrong with them. That's undoable. And so, God bless you that you're doing it, but very hard. Um, I'm completely capable of writing a very grumpy, pessimistic book because I wrote one 10 years ago about the electronic health record, where I was completely disappointed, in some ways flabbergasted by how badly things had gone. Um, but I came out of this process really quite optimistic. Now, I don't think naively and stupidly optimistic because I think there are lots of things that can go wrong. But this is the Biden's old line: don't compare me to the almighty, compare me to the alternative. And the alternative does not work for patients, for doctors, for nurses, etc. What's the greatest impact? I think ultimately decision support. I think ultimately the ability, I'm a generalist as you are, I'm a hospital, so I take care of sick people in hospitals. And on rounds every day, and I've tested this when I was writing the book, I might have 10 or 15 questions that if I was lucky enough to run into my favorite nephrologist in the cafeteria or ID doctor or cardiologist, I would say, Emma, can I run this case by you really quickly? I can't, I don't, but I can pull my phone out and ask open evidence that question and get, in many ways, a subspecialty level knowledge. For the patients who have no access to a primary care doctor and, or have a chief complaint and do they have to go to the ER, urgent care, I think those are remarkable capabilities. I think in the short term, a lot of it really is the administrative silliness. It is the prior auth writing, it's the billing, it's the coding, it's the that kind of stuff. And I don't think that's the game changer, but I actually think it's quite important because for both you and I, we probably went into this pretty skeptical. And now you're using it and you're a fan. And you're using it because
Yeah,
it makes your life better. And I think it makes you open to using tools that are more sophisticated, maybe a little riskier, but have more of an upside over time.
absolutely. I mean, now if Nabla is my ambient scribe that basically listens to the patient and then it helps me write my notes. Now I curate it, I sculpt it at the very end, I fact check it, but it's pretty darn good. It also serves as my peripheral memory bank. So if I have an hour-long annual physical with an older patient, for example, and they mention something about an hour ago into our conversation, I won't
Mhm.
necessarily have remembered it if I were writing my note, like hunting and pecking on the keyboard by myself at night. Whereas the AI will remember all that and bring it back to my attention to make sure I cover it in my note. So it's astonishing. If it's broken, it's kind of like akin to your cell phone being dead and you're walking around the world without a cell phone. It's an essential tool. It's so essential. Um, what do you make, Bob, of the data on, comparing an AI to a human on diagnostics? I mean, there are now studies showing, like at the New England Journal published a study showing that I can't remember the exact specifics of this study, but that if you compare AI to humans, like AI wins maybe the majority of time in terms of making diagnoses. What do you make of that? And what do you think the downsides and upsides are of that?
Well, first of all, I do buy it, but I think the studies are biased by the way they're done, and the way they're typically done is a case highly curated is presented to the AI. This is a 82-year-old patient with CLL who comes in with a fever and a white count and a pulmonary infiltrate and a creatinine of 2.3. What do you think is going on? Before we say let's jettison all the doctors, the creation of that narrative is an intensely cognitive act. And that's
It's
part
a
of the
great
reason
point. It's a great point. It's a terrific point.
it's part of the reason that comparing, people sometimes look at stuff like that and say, oh, if these tools were just given to patients, and they are, obviously people can put stuff into GPT or Gemini, patients can diagnose themselves. Well, that act of taking 100 potential facts and distilling it into the 6 salient points you're going to put into the machine is really cognitively complex and takes a lot of experience and education. So I think the studies are real. I buy it. I mean, I think it's one of the great challenges. You just said you review your Nabla note, but if it were right the 99 times in a row, are you really really awake if you're reviewing number 100? Probably
I
not.
mean, I'm
If you're
reviewing
human.
it a lot less carefully than I did a year ago. I mean,
Of
I
course,
trust it almost more than my own memory. I do.
of course. I think in some ways, and one of the more interesting questions I grappled with in the book was for the foreseeable future, whether it's on diagnosis or drafting your note, the tools will be good enough to be useful and not perfect enough to be entirely trusted. So the systems we'll create are the human in the loop, meaning the human is the final arbiter. The human is the one who's going to get sued if something goes wrong. And those are less safe than you would think. One, because humans are not good at that if they've learned to trust the tool as you have. The second is we'll de-skill over time. We'll be less good at the thing over time because we don't do it as much. And then the third is the problem you're bringing up, which is at some level of correctness, the tool's going to be better than the human, and therefore, if you insist on human intervention, there's a decent chance the human will screw things up. So these are pretty daunting problems as we think through how do you get the design of these human AI dyads right, and there will come a time for certain tasks where the AI is so good that you don't want the human intervene, that we should trust the AI as being perfect.
So I have another question for you. As someone in medical education, I mean, you are at one of the top, if not the top. I mean, I trained at Harvard Medical School, so we're one of
They're okay too.
the UCSF is like at the top as the top one of the top hospitals in the entire country, and you're the chair of medicine. You are training residents, fellows, medical students. How do you see AI affecting medical education, medical training? I saw this week a gallbladder surgery, a cholecystectomy is a gallbladder surgery done by a general surgeon, done by AI.
Hmm.
That apparently was done with immense precision and perfection and did not require a human. So, like, what does that say to the general surgery future resident or the medical student? Like, how is this going to change the landscape of medical education?
Yeah, I can tell you in the med ed world, this is all we talk about. There are parts of it that are easy and parts that are hard. The easy part is we have to teach our trainees about AI, how it works, when to trust it, when not to trust it, what's a hallucination, how to be the human in the loop. We also have to be thoughtful about setting up the system. So the fact that you get ascribed the nanosecond it's ready, I'm not sure the student gets ascribed the nanosecond it's ready, because we want to teach the student how to write a note. And then maybe when they've achieved proficiency in that, maybe we roll out a scribe. The same thing is probably true in assisting you in surgery. I think the hard question is what to take off the curriculum.
Right.
And when Google first became a thing, there was a narrative like we don't have to teach facts anymore because you can Google everything. And that would have been a massive error, because it turns out that you can't Google everything. You can't, don't have time. And even though these tools are better, I do think for the foreseeable future, having expert level knowledge and skill and diagnostic reasoning ability to essentially use the tools correctly and interpret the results of the tools correctly, I think is going to be remain very important. Does there come a time where the tool is so good that we can stop teaching the skill or stop emphasizing skill? Maybe. I mean, our residents are not as good in the physical exam as I used to be, but there's a reason for it, which is they use POCUS. They use bedside ultrasound. They have technology tools that, I can be romantic about the physical exam, but they're better than me laying on trying to feel your spleen. And so I think this is a very knotty problem. I do think that in the short to medium term, I think we've got to be very careful about taking too much of traditional diagnostic reasoning skills off the plates. And I think the other thing I'd say is it's sort of easy to project that we're not going to need doctors for A, B, and C. In 2016, a guy named Jeff Hinton, who was the founding father of the new AI, generative AI, won the Nobel Prize last year, gave a speech. And this is 20 obvious that within 5 not going to need them anymore. The AI is going to be the
Bother your
applications
face.
tanked.
Yep.
And then 2 years later, the students woke up and said, "Wait a second, the radiologists still do earn twice what a primary care doctor earns. We can't hire enough of them." And it turns out at UCSF today, in a city where we're all taking driverless cars, we can't hire radiologists fast enough, and the radiologists are begging for AI to help them. Because the volume of scans has gone up so much and the AI helps a little bit with productivity. So I think we've got to be pretty humble when we say, stop teaching teach in a different way. Now, there's a lot of other stuff in medical education where the AI helps a lot. For example, a feedback tool. Right now, the medical student goes and interviews a patient, then comes out and tells me about the encounter. You can imagine a world where the AI is listening to the conversation and gives them feedback on how they did. Those sort of things. Precision education, where we look and see, they've seen a lot of patients with heart failure, but they haven't seen enough patients with diabetes. You need to see a simulated patient with diabetes to be sure you know how to manage that patient. Those sort of things I think are real advances in AI, but let's be really careful about taking too much physician level skill off their plate.
I love hearing that. It makes me feel like we're not going into the abyss of like just, canceling the class of, 2027 admissions and just replace them with computers. I did not think that's what you were doing at UCSF.
No.
Does it also in med ed in the conversation about residency programs and medical training, does it also invite a conversation about like the humanities and the sort of patient doctor relationship and like is it possible that it could elevate that sort of element of care? I don't know if you know my friend Suzanne Coven up at Harvard Medical School. She's a writer. She's kind of like the female Atul Gawande, I might say, who's a writer about like the patient doctor relationship and humanism in medicine. I wonder if in med ed, if there's going to be more of an emphasis on like the relational aspects of delivering care because the AI is going to be doing so much more of the transactional elements that don't require humans. I don't know.
I hope so. I think that would be kind of a healthy outcome to say, what is the. I think what we're going to be doing is deconstructing what a doctor does
Yeah,
and saying what are the parts of this that are more transactional, more algorithmic, really don't take your level of training, your experience, or require your income, frankly, that can be done more conveniently and less expensively by some other technology. And then what are the parts that are not that? And as you describe your relationship with your patients and the kinds of things that you did in terms of coaching them or listening to their concerns and answering them sensitively, that in some ways becomes disproportionately important. And you could argue we've underemphasized it maybe because we've had to spend so much time teaching all the fact stuff. And maybe there's a trade-off there that we maybe dial down certainly the amount of time that they have to spend on all the transactional parts of medicine, but maybe there's a golden era where we have in some ways reclaimed the humanity of being a physician, and in some ways that is our secret sauce that the AI can't quite replicate. Even as I say it, though, there are studies that show that if you take a blinded observer and give them an answer from AI and an answer from the human doc, they often find the answer from AI to be more empathic. Now, the retort to that, of course, is the AI answers tend to be longer because they have more time. But yes, they have more time. I mean,
that's
that
right. They
is
got loads of time. They
they
got
got
loads of
they got
time.
they got all the time in the world. So I'm hopeful that that will happen. I think that would be a good outcome. But I think the bigger issue is like really taking a step back and saying what parts of what we do are really immutably human. It's easy to say, telling a patient they have new onset of kidney failure or diabetes or cancer. But if your day is organized, like what does that look like? That's all you're going to do and everything else that's not going to work. So I think what's going to happen more likely is we're going to sort of look at the job of a primary care doc and say what parts of it could be done by AI. Think there's a little bit of a problem there, which I'm guessing when you look at your schedule in the morning and you see cholesterol, weight, okay, and then there's the patient like 9 problems and unbelievably if your entire day was that patient, it would be like, "Oh my god, how do I get through my
Yeah,
day?" So we're gonna have to figure out, make sure you have enough time and bandwidth to do that if we've taken all the easy stuff off your plate.
100%. That's true. And that's exactly what the EMR did, right? The EMR just was trying to help doctors be more efficient, but in so doing, it basically created a massive amount of burnout because we were not only, strapped with like busy schedules without much time because we're not rewarded, incentivized to spend time with patients. That's just on our own, you know, conscious. Um,
Yeah.
but then you had, more information, more portal messages coming in. And so the reason why doctors are burned out is not because we don't love caring for patients, is because of the administrative burden. So to the extent AI can help alleviate that administrative burden to then elevate the patient doctor relationship, I too am hopeful about that. The other thing is, I mean, it's such a low bar in this country. The healthcare system is so broken, it's so fragile, and people are starved for access to information that is fact based. And I think a lot of people would take an AI that knew a little bit about their diagnosis and was, centered on fact-based information when it would take them 3 months to get into the doctor to begin with. And then they'd have to fill out form after form after form, and then the doctor may have 5 minutes and the doctor is rushing out the door. So to me, the scalability and the access to information is wonderful. I just think, as you well know and pointed out beautifully in your book, there are real, privacy considerations we have to face. There's who's training the AI. There's, how do you build in like or how do you take out, bias in these systems? I mean, if you're talking to a
And
patient and
look at social media, these tools came out with all the hope in the world, but were tuned because it was to the economic advantage of the company for engagement. And when you're tuned for engagement, the crazier the better in a way. And so there's a lot of risk here, as particularly if you think about patients now maybe not seeing you, but getting their care from AI that's built by a company that didn't take the Hippocratic Oath and is going to be trying to maximize revenue. I don't say doctors are angels in that regard, but I think there's something about the responsibility that we feel and our training that drives us to balance to some extent our economic interests against the needs of our patients and put the patients first. I have very little confidence that an AI, Silicon Valley AI company will do that. Some of them, these are very good people, but they're going to maximize their economic advantage to the extent that drives them to do the right thing, create a tool that's very useful and convenient and gives the right answer. Fabulous. But there are other forces at play that could cause this to be not quite so cheery.
That's right. I hope I can send you a copy of my book. It's coming out in August. The advanced reader copies are coming out next week. It's related to this because the book is called Beyond the Prescription: a doctor's guide to taking charge of your health. Basically, it's a 5-step guide that's a broad framework to help consumers, patients, readers of this book um, navigate this messy landscape between the broken medical system on the one side and the beckoning wellness industry on the other side. When we all need a doctor or a medical provider to help guide us through various parts of our health, we also all want to be well. But both industries are failing people. They're overly prescriptive. They're rigid. They're not necessarily tethered to the reality of the patient's needs or goals, or in some cases, evidence. Um, so I hope I continue this book because my hope is not just to be like on the Today Show, which would be lovely, like you are doing all the media circuit with your wonderful book, but also to have it be a calling card to help be part of the reinvention of healthcare, leveraging AI to elevate the relationship, not eliminate it. Because I do think no matter what you and I do, even if we were fighting AI, which neither of us are, AI is coming for healthcare. AI is already here. And I think if we can help shape it, I hope you're thinking the same way too, that you want to be part of the solution to healthcare in this
Absolutely.
country, as I very much do, because it shouldn't just be for a few people or a small subset of people who can afford to pay for a doctor. It should be for everybody. And I do think there's promise that AI can elevate that experience um, without sacrificing quality, but that remains to be seen who's going to do it first.
Yep. Yep. No, I'm with you. I look forward to reading your book, and maybe we can get Amazon to sell them as a package price.
Yeah, 2 for 1.
Two for one.
But
There you go.
I hope everybody picks up a copy of Dr. Wachter's book, whether you're a physician on this call, whether you're a patient, you're like you love technology or hate technology. It's a really, really wonderful, well thought through book, and I loved all of your interviews, and I thought that you picked really interesting people, and I loved the optimism. I know you're not an optimism for optimism's sake. You're an optimism because you have facts and data and experience. And I really appreciate you joining me today, Bob. It's always fun to talk to you.
Thank
And I
you.
remember our COVID days I mean, gosh, what can you believe what we all went through?
It's staggering. It feels like 100 years ago. The fact that it was 4 or 5 years ago is just crazy. But in a weird way, gratifying, and a very similar experience to this in a way. Just I'm not the world's expert on informatics or AI. I wasn't the world's expert on COVID, but there is a place for people that are generalists that are pretty good at kind of big picture and pulling stuff together, and then trying to communicate in a way that people find useful. And that's a
Well,
gratifying part.
I remember you. I mean, people were listening to you on a wide audience. And I remember when you had COVID and your wife had COVID, you were putting up your rapid test and your negative test, and everyone's kind of rooting for, oh God, Dr.
Yeah.
Wachter.
Yeah, there was, I mean, I still have people come up like world experts in virology, and they will say, during COVID, my mother wouldn't listen to me. She wanted to know what you thought. It's like, really? Are you kidding me? But, I certainly don't want to do that again, but it was gratifying. I mean, we're in this to help people and explain things in ways that people find useful. So,
That's right.
uh,
That's right. That's right. Well, you do that well in the book, and I am grateful for your book, grateful for your time, and I hope you have a great weekend. And I'll talk to you next time.
great. Thanks so much.
Okay,
This is
bye,
super.
Bob. Thank
Take
you.
care.